Uh, Thank you very much. And first of all, let me congratulate to all of you. A very happy nursing week, and it's a great privilege to be here to speak on a very important topic, that is post resuscitation care. Basically, why it is important, because after the achievement of the return of spontaneous circulation, that is ROSC, rearrest is very common, and then the cardiogenic shock, and then there's a brain injury, and all these lead to a poor outcome. So how to circumvent that problem and how to overcome those hurdles, that's what the post resuscitation care talks about. All right, as we know, that there are 6 links to the adult out of, and now we are going to talk about the fifth link, that is the reach to the hospital, and then how to manage these patients so that we can have a better outcome, better survival, and a survival with a very little disability. This is a brief data. You can say that we don't have any data from the India, but we have data from the US, and this is the one of the best state where the out of hospital arrest they receive CPR, and those best of scenario, only 60% of those patients who had a cardiac arrest in out of hospital receive a CPR, and of all those 60%, these 15 to 20% only they have a return of spontaneous circulation. That is our motto of basic life support. And of these, when they reach to the ICU, only 5 to 10% survive. And these, when those survive, only 7% have a minor sequelae. Rest have, most of them have some sort of major sequelae or major disability. Why it is important? Because post registration there is a cardiac arrest, there is continuing shock, and because of these cardiac arrest and shock, there is a brain damage. So scenario is now changing over the last, you can say, like last 15 years. When we see that when the patient reached to the hospital, there was hardly any difference in the mortality. But nowadays, the mortality is better. There is a 50% more chances of survival when the patient reached to the hospital. And this survival is much higher when the patient is younger patients, and less in the elderly patient, but the younger patients survive more when they reach to the hospital, and the post-registration care is instituted early. So what are the goals of post-registration care when patient has achieved a spontaneous circulation? So what are the is to maintain the normal cerebral perfusion. That is utmost goal. And then we have to achieve a stable cardiac rhythm and adequate oxygen and have a better quality of life later on after the discharge. So what are the major problems, and what are the care priorities for what is we have know that in the initial phase there is a high chances of rearrest. When the patient develops particular arrhythmia by VTV, there is a high chances of rearrest. We have to prevent this rearrest, and then we have to maintain his oxygenation, and then we have to try to find out what the cause of arrest, because the cardiac arrest is the final you can say the final destination, but what is the cause of arrest? So we have to identify and try to treat that problem. Someone is then we have to stabilize the patient and prevent the brain injury, because the brain injury, if there is a continuous hypoxia or hypotension, there is a continuous brain injury. We have to prevent that. Then comes to the early risk stratification, whether this patient requires early surgery, whether this early angiography, and then you have to communicate to the patient's relatives, family counseling, and then a final disposal. So these are the 4 headings under which I am going to discuss the post-resuscitation care. So why it is important? Because 4 of 10 patients who initially regain that majority of these patients who have a return of spontaneous circulation, we have already discussed about the return of spontaneous circulation, they have a development of hypertension. They have continued to have hypertension. So what we have to do is that we have to initially stabilize and prevent this arrest. How to do that? How to achieve that? We have to, for the circulation, we have to have initially we have to have vascular access. Why it is important to have vascular access? Because we have to administer fluid, we have to administer vasopressor and other medication. And then remember, CVP line is not important at this point of time because we have to maintain the blood pressure. We have to achieve our goal, and this CVP line insertion at this point of time from achieving our goals. And then the invasive blood pressure monitoring. This is also not very important at the initial phase of research. Adequate perfusion you can assess by the you can feel the pulses, you can see the plethysmography waveform on the monitor, and then you can see that the adequate blood pressure is being maintained or not. And then IV fluids. IV fluids are very important because these arrested patients, they are very much preload dependent, meaning by you infuse the fluid, their pressure comes up. And you have to infuse the fluid around 1 to 2 liter in a very rapid manner with the pressure bags. Remember that you have to be very cautious. Cardiac patient, a known case of cardiac failure, a patient is having any evidence of pulmonary edema. How to diagnose the patient is having pulmonary edema? The patient is having faint frothy sputum. You are hearing crackles on auscultation. If there is a stiff lung, there is a difficulty in achieving the oxygenation. The ambu-back is you are feeling there is a very stiff. Then you have to be very cautious. You have to decrease the fluid infusion in these type of patients. So vasopressor are important because you have to simultaneously initiate vasopressor. NORAD drip is very important. You have to start. Dopamine is not being used nowadays. Remember, when you are preparing for the IV drip, this infusion for the NORAD infusion, you can push adrenaline or epinephrine in 10 to give you some time to institute your infusion of NORAD. What about the airway and breathing? See, bag wall mask ventilation or supraglottic airway ventilation is good enough. Don't jump for the ET tube intubation at initial phases of life. So we have to, this ET tube is required when you're suspecting there is an airway obstruction. And intubation can be deferred when you're sure that the oxygenation can be achieved. There is SpO2 is more than 92%, and there is a chest intubation can be deferred. If it is oxygenation could not be achieved, then you have to go for the rapid sequence intubation. What about the recurrent arrhythmia? These patients have, if the patient is presenting with a tachyarrhythmia, they have high chances of recurrence. How to manage that? You have to follow the ACLS protocol, which I think already discussed. And remember, if the patient give IV amidron 300 milligram IV push or lidocaine. If the patient is having recurrence, then continue infusion. I'm not going into the detail about the ACLS protocol because I think it's already discussed. So now what is next? Now you have to identify and treat the reversible cause of cardiac arrest. Why it is important? Because the cardiac is the final common manifestation of numerous disease process. Whatever the disease process, ultimately that patient is going to have cardiac arrest before he passes away. So I have just highlighted the important causes of cardiac arrest. Cardiac cause is the most important cause, and most often it is a treatable cause. Acute coronary syndrome, meaning by acute myocardial infarction, whether there is a non-ST elevation MI or ST elevation myocardial infarction or unstable angina, this is the most common cause of any cardiac arrest. arrhythmia, whether it is a tachyarrhythmia or bradyarrhythmia, ventricular tachyarrhythmia or ventricular tachycardia or ventricular fibrillation or heart block, the arrhythmia is the next common cause. Respiratory is there is acute airway obstruction that can cause cardiac arrest. Pulmonary embolism is a very important cause, and you know the pulmonary embolism is the number one killer in a ICU setting. Number one killer in the ICU setting. Attention pneumothorax, another important treatable cause and very important cause. We know that there is trauma, GI bleed, intracranial hemorrhage, opioid overdose, and potassium. Remember, in a patient in ICU setting, and especially in the cardiac ICU setting, long QT syndrome is a very important cause of sudden cardiac death. And of the long QT syndrome, that the potassium hypokalemia is the number one cause of long QT syndrome. So we have to search for the cause and etiology of this cardiac arrest. How we are going to do? We have to take history. Most of these patients are comatose. We have to take history from the family members. What we have to listen to the family members, what they tell about the antecedent symptoms. Suppose sort of acute chest pain and suddenly collapse. We know suspect that this patient is likely to have acute coronary syndrome, and the patient complained of severe headache and suddenly collapse. Then we can think of that this patient is likely to have intracranial bleeding or something like that. And then the patient had acute blood loss because of any reason. That history can be obtained with the or any. Suppose the patient there is a past history of cornea is the number one cause. Simultaneous examination, physical examination, if there is a rigid abdomen, we can think that this patient is likely a surgical emergency. It's a case of acute abdomen. If you're in the nasoplastic tube or there is a rectum, blood in the rectum, then you think that there's a hemorrhagic cause. And then you can, if there is a one limb is swollen, if there is a deep vein thrombosis, then think of the cause of cardiac arrest. And IV drug abuser, there is a telltale sign in the IV drug abuser. There is a needle marks in the forearm. And we can, if you're finding there is a sepsis, a source of sepsis, for example, the patient is having cellulitis in one limb, sepsis is likely cause of this cardiac arrest. All right. So after that, you have to do the baseline neurological examination. Why it is important? Because we have to look for the possible cause. We have to look for the likely clinical course if the patient very deeply comatose, that patient is likely to have a great prognosis, and there any need for the neurological intervention if it is required, and it is about the life that. So remember, asymmetrical neurological findings are not because of cardiac arrest. They are almost because of the intracranial lesion or acute stroke. Meaning by patient is not moving one limb or one hand, or one, it is likely the patient is having acute intracranial stroke. Brain stem responses should be elicited because papillary corneal log act reflex, that is a routine. GCS score and 4 score should be calculated. Then what are the diagnosis? Why it is important to do diagnostic test? Because we have to determine the etiology, and then if you are doing for position ET tube, you can see the position of CP line. You can see whether there is a trauma to the chest or something like that, and then ascertain the function of a specific organ system, for example, liver function test and the kidney function test, and then assess the severity of the injury. So what type test? Basically, ECG is the most important. Lab test, imaging studies we all discuss. So ECG, remember that initial ECG, if there is a ST elevation, and that could be because of the arrest itself. That could be because of the arrest itself. It may not be because of the acute myocardial infarction. Why there is danger? Because of the global ischemia, because of cardiac arrest, and we are in NORAD or adrenaline, that can also contribute to the elevation of this ST segment in initial phase. Remember, this ST segment is usually in the initial 5 to 7 minutes. And after the 5 to 7 minutes, patient is still having a ST elevation, think of myocardial infarction. So if the patient is having ventricular tachyarrhythmia, VT or VR, think of acute coronary syndrome as a cause of cardiac arrest, and this subjected early angiography. And then we have to also look for the electrical axis, T waves, etc., and all the changes. And then importantly, we have to calculate the QT interval. See, QT number one killer in ICU setting. If long QT is a number one killer in the ICU setting, it could be because of the long QT syndrome itself, or it could be because of the hypothermia. It could be because of electrolyte abnormalities, as I already discussed. That hypokalemia is the number one cause of long QT syndrome. If you're finding a right heart strain, meaning by right axis deviation or something like right ventricular strain, then think of acute pulmonary embolism. Massive pulmonary embolism is the cause of cardiac arrest. So bedside echocardiography available, well and good. If it is not, then you can achieve these findings with the help of the ultrasound. If you are finding there is a regional wall motion abnormality, which seems to be of recent onset, then think of acute coronary syndrome, and this patient should be subjected because of the cardiac arrest, because of this global hypoperfusion of the coronaries. Lab testing, arterial blood gas should be obtained as early as possible. Arterial vascular access, meaning by you using vasotropic agents, you have to maintain the blood pressure, you have to measure blood pressure and titrate the and then we have to measure the sodium, potassium, chloride, and bicarbonate. We know that what are the importance, what are the implication of this, and the rapid fluctuation of potassium are very common. This is because of the ischemia, acidosis, or infusion of NORAD infusion. But both hyperkalemia and hypokalemia, they are very, very dangerous, and they can cause arrhythmias. And hypokalemia is and correct the magnesium. Blood count, we know that the initial TLC rise is very common after the arrest, but it is if it is very high, then think of some infection. Anemia will tell you, it decreases hematocrit will tell you that if the patient is having some sort of bleeding inside. If the patient is rising troponin, then think of there is a chances of acute coronary syndrome. Mild elevation is very common because of the global hypoperfusion, because of the NORAD, because of the CPR, etc. So mild elevation is not the lactate usually it is the, and if it is a continuing some sort of muscle or abdominal discomfort, abdominal issues. And then look for the toxicology and the and see for the kidney function and liver function test. Imaging studies, chest radiograph is very important because we have to look for the pulmonary pathology, and then we have to simultaneously we can see that the ET tube position and CP line position, and pulmonary edema aspiration are very common and could be the cause and maybe not related to the cause of arrest. That could be unrelated, and then that aspiration could be because of the after the arrest. Pneumothorax, if you can finding in on X-ray, then it's a very important treatable cause. And mediastinal winding, if you're suspecting mediastinal, then think of aortic dissection. Bedside ultrasound is very important because you can find out cardiac tamponade, pneumothorax, pulmonary embolism, interperitoneal bleed. All this can be seen by the ultrasound, and you can also assess the right ventricular function. Right ventricular function are very much depressed in the case of massive pulmonary embolism. IVC can be assessed, and if the IVC is, you can see the volume status. If the IVC is dilated, you think that the volume is good. If it is IVC collapse, and global count only. Computed topography, depending on the type of patient are you dealing with, you can do a different type of protocol of CT angiography. And then comes the ongoing stabilization and prevention of brain injury. How to achieve that? Respiratory consideration. What we have to do is that We have to ensure a patent and functioning airway. We have to maintain a saturation of more than 94% and with the PaCO2 of 40 to 45%. And for the achieve the hemodynamic consideration, we have to keep a mean arterial pressure above 65 millimeter mercury. And whether you are going to use IV fluid or vasopressor or anadrop or mechanical circulatory support, you have to achieve mean arterial pressure above 65. To prevent arrhythmia, antiarrhythmic drugs are not required. They should not be given because they are also proarrhythmic. And it is reserved only when the patient is having unstable arrhythmia and recurrence of arrhythmia. Revascularization. If we are suspecting the patient is having ST elevation myocardial infarction, if there is a cardiogenic shock and there is a rising troponin, then think of a cause as a cause of cardiac arrest, and then rush this patient for coronary angiography and revascularization. And don't wait for coma to recover. You have to do as a temperature management is very important. We have to achieve normothermia, and because if you vascular damage, and then the mild hypothermia is now the in thing. They are now it is being recommended. You have to achieve a mild hypothermia, and to achieve that, we have to infuse a cold saline infusion, and that has to be started as early as possible and continued for at least 72 hours. Remember, this mild hypothermia is also associated with some sort of adverse effects, such as the mild coagulopathy, hypokalemia, hyperglycemia, and then there is of bradyarrhythmia. After achieving all that, we have to also look for the other early intervention. What of that? We have to we have to raise the head of the bed up at least also to decrease the intracranial stress. Prophylactic therapy is usually not recommended if you are suspecting the patient is having some aspiration or some sort of pneumonia. Start antibiotic therapy as early as possible. Glycemic control is important. We have to maintain the this is hypoglycemia, and there is an increased neurologic. Seizure and myoclonic jerks are very common if they are present. Very severe brain injury, and to prevent that seizures and myoclonic jerks, we use the sedative which have anticonvulsant properties such as propofol or midazolam are the drug of choice, and they have given in IV infusion. So after that, we have to risk stratify, then we have to communicate to the patient and the final disposition. So assessment of brain injury, it is very important. It has to be done repeatedly, almost daily, because initial assessment of brain injury should not be used as a justification to limit or withdraw critical care. आपने initially देखा patient बहुत ही deeply comatose है, you think that this patient is not going to make, that should not be, you should not remove from the critical care, because initial assessment is almost always fallacious. Initial family communication, you have to give a broad overview about the percent to 90%. Patient is whether it is going to fall into 20% range or 90% range. And then you have to go for the final disposition. So it may require, say for example, a patient is having acute coronary syndrome, we require coronary acute angiography, and that patient has to be shifted to cardiology. A patient is having acute intracranial bleed, then patient may require neurosurgery or neurologic care, and then the patient may require a mechanical circulatory device. It's based on these proposition, then you can shift the patient to specific. Conclude my talk is to take home message is that our goal of post-resuscitation care is to achieve a normal cerebral perfusion, a stable cardiac rhythm, and adequate quality of life after that. Electrocardiogram should be recommended in a patient with ST elevation myocardial infarction. If there is a rising troponin or there is a new onset of regional abnormality in echocardiography, and continuous stabilization and try to prevent brain injury. If your center is and then you have to treat and don't give speculative details and the final disposition to the respective departments. Thank you very much. Now I'm ready for any question if there is.